I'm Charlie Eaton. I'm a hand surgeon, and I'm also the founder and executive director of the Dupuytren Research Group, which is a nonprofit that advocates for people with Dupuytren disease. I initially got involved with Dupuytren as a hand surgeon because hand surgeons are the people that treat Dupuytren disease. My practice evolved into a Dupuytren specialty practice, and over the years, getting to know and personally treating thousands of people with Dupuytren disease, I came to three realizations about Dupuytren that I really hadn't read in books. The first is that Dupuytren is a much bigger problem, both in terms of numbers and personal impact, than is generally recognized by the medical community. The second is that Dupuytren is underserved. There are many people who ultimately wind up permanently crippled from Dupuytren disease, despite the best that doctors currently have to offer. And the thing that people need with Dupuytren is not an incremental change, not just something that's a little bit better, but a fundamentally different approach to treating Dupuytren. The third thing I realized is that this has been going on for a long, long time. We're still operating on the same basic treatment model that's been around since the disease was first named almost 200 years ago. And we haven't made any significant progress in long-term or lifetime outcomes since the last big operation was designed and refined for Dupuytren back in the early 1960s. And that really has to change. But given this track record, it's unlikely to change unless somebody does something. What Dupuytren really needs is a dedicated, collaborative, and successful campaign to bring new research tools to bring the same kinds of advances to Dupuytren as have happened with other diseases in the last few years. And that's what the Dupuytren Research Group is doing. Our goal is to minimize the burden that people have, both from Dupuytren and from its treatment. That sounds pretty lofty. That's actually the goal of all doctors treating all diseases. That's kind of the definition of healthcare. And it ought to go without saying, but it can't go without saying because this is exactly where we're stuck with Dupuytren. This is where we're not making progress. We're not reducing the impact of Dupuytren, and we're not really reducing the impact of the treatment that we have to offer. And that is the goal of this organization. Dupuytren has kind of fallen between the cracks, and this is why. Dupuytren disease is a medical condition. It's a chronic medical condition that causes changes in the hands and in other parts of the body. And medical doctors, physicians, treat medical illnesses, and medical doctors are the ones that do chronic disease research that come up with better treatments for medical diseases. But medical docs don't treat Dupuytren. Surgeons do. And surgeons provide mechanical treatments for mechanical problems that arise from disease. And they don't do chronic disease research. Surgical research is technically oriented, and it's biomechanically oriented. And surgical research won't come up with the kinds of answers that you need to treat a medical disease. And so our goal, once recognizing this, is to act to fix that. And the first step of fixing that is awareness. And that's why I'm here tonight. We'll talk about what Dupuytren is, what its impact is, research for a cure, advocacy, and then we'll open up to have a discussion about anything Dupuytren related. Dupuytren is sometimes hard to describe, and if you ask a hand surgeon what Dupuytren is, chances are you'll fall into a pit of jargon. The doctor will start talking about stuff that doesn't clearly make sense. We'll start saying things like, well, there's this layer of fascia under the skin, as if you know what that is. Or there are these myofibroblast cells that are working, as if anybody knew what they were. Or it's kind of like what happens when an open wound heals. And all that's dancing around the fact that nobody really knows what Dupuytren is. We know it's a medical condition, we know it causes things to happen, but we don't really know at a molecular level what's really going on. It's a medical condition that affects the hands and other parts of the body, and in its late stages can make fingers permanently bent. But it affects areas other than the fingers, and it's often missed or misdiagnosed, particularly in the early stages where it's sometimes hard to diagnose. Dupuytren classically is a problem of the palm. It causes visible changes in the palm, 3 kinds. Lumps in the palm called nodules. Strings under the skin are called cords. And then a finger that can't be straightened because the cord is too tight, that's a contracture. And those are the 3 visible changes that take place with Dupuytren. The progression of Dupuytren in terms of contractures tends to bring the fingers down to the position they're in when the hand's relaxed. That's kind of the end stage of what Dupuytren usually does. Now it may change when people try to lift their fingers back, but untreated, and if it goes on and on, which it doesn't in everybody, it tends to bring the fingers down like that. So that lets it fly under the radar and people don't notice it. I might have a bad bend in my finger and you wouldn't know it because my hand looks normal and relaxed. You wouldn't be able to tell unless you saw me try to straighten out my fingers, and I couldn't straighten out my fingers. And so it flies under the radar that way. There are also invisible changes, things that people are aware of but don't show on the outside. A lot of people with Dupuytren early on, about 1/3 of people, will have funny feelings in their palm when nodules show up. Itching, burning, stinging, a feeling that something is just wrong. Tenderness, some people will complain about their hands just feeling funny when they're sleeping at night. Feeling that some people will have before they have any bends in their fingers. They'll describe the feeling of their hand as if they had rubber bands in their palms. Isn't something that you can see. And a fair number of people early on will have difficulty doing fine manipulation, doing normal activities that require some dexterity that they used to be able to do easily and then find they have trouble doing. The natural history of Dupuytren we know a bit about. Dupuytren is treated by surgeons, so we know a lot about what happens after somebody's had treatment of a bent finger. We don't have nearly the amount of data on what happens as someone's going to the point of having a finger that's bent enough to need treatment. But crunching through the numbers, here's kind of a breakdown. If someone starts out with a lump in their palm, then over the next 10 years, about half the time they'll develop a cord in the finger, and less than half the time that cord will progress to the point of needing a procedure to straighten out the finger. So that means that starting with a lump, about 1 out of 5 people over the next 10 years will progress to the point that they'll need to have some kind of treatment. And what happens to the others? Well, about 10% of people, 1 out of 10, the lump will go away on its own with no treatment at all. And the remaining 3/4, the lump will either stay the way it is, or there may be a little bit of a cord progression, but not enough to need to have any kind of treatment. And that's actually good news because most people with early disease don't progress rapidly to need to have some kind of treatment. But it also means that there's a lot of uncertainty about what happens to people early on. And the importance of that is that if you wanted to do some kind of preventive treatment and you wanted to test how well the preventive treatment worked, you'd have to know what to expect if there wasn't any treatment. And it's really hard to predict. So if you gave someone a medicine you thought would work for Dupuytren and the lump went away, well, it might be what was going to happen anyway. Dupuytren affects other parts of the body. So people will get lumps on the back of their knuckles, typically on the knuckles that you'd knock on a door with, but any of the backs of the knuckles on the fingers or thumb or even on the backs of the toes can show up. They're called knuckle pads. People can develop lumps in the arch or the instep of their feet called Lederhose. Now, there actually was a Dr. Lederhose. It's not the same as Lederhosen, the German word for stocking, although it's pretty close. There's also a condition called frozen shoulder, which is more common in women than men. It's not the same as rotator cuff. Frozen shoulder is a painful problem. It starts fairly quickly over the course of days or weeks in which somebody has trouble lifting their arm up, and it tends to run with or without treatment for about a year, year and a half, and then it tends to burn itself out, and most people lose some of their full range of motion as a result of that. And there's a condition called Peyronie, which affects the penis and can cause the penis to bend or be painful with erections. Obviously more common in men. Taken together, these are what you'd call Dupuytren spectrum diseases. And this is kind of a family of diseases. Dupuytren, knuckle pads, Lederhose, Peyronie, frozen shoulder. If someone has one of these, they're more likely to get one of the others. So, for example, about 1 out of 5 men with Peyronie disease will also have Dupuytren. Also, the more of these you have, the more severe the disease tends to be. That is, it tends to progress a bit more rapidly, and it tends to come back after treatment a little bit more rapidly. So those are Dupuytren spectrum disease, and what these actually point to is the fact that Dupuytren is something that's in somebody's system. It shows up in the hands, but it really is throughout the body, and it shows up in different areas. The anatomy of Dupuytren can be pretty complicated, but only because the anatomy of the hand is fairly complicated. This is a view of the layers that are just under the surface of the skin. There are different sheets of tissue that go in different directions and are perpendicular to the skin, and they're one on top of the other that are attached to the undersurface of the skin, and they are attached further down all the way to the bones in the back of the hand. And these are the areas that can be involved with Dupuytren disease. What these tissues normally do is they hold the skin down to the palm. And the fact that they're attached is why the skin of your palm doesn't slide around, why you can grab and hold on to something securely. Otherwise, it'd be like wearing loose gloves. The sole of your foot is the same type of construction. Otherwise, it'd be like walking around in loose socks. And to that extent, that everything's sewn together through multiple layers, the palm is kind of like a quilt. So when you make a quilt, you lay down a layer of fabric, you put down a layer of padding or batting, another layer of fabric, and then you put stitches through all the layers. And those stitches keep the top and the bottom layer from sliding relative to each other. And depending on how tight the threads are, you can either make the surface dip in or bulge out. You can adjust the contour. And the palm is very much like that. So in the palm we have the creases in the palm, which are areas where the attachments are a little bit tighter. And we have areas where the skin is a little bit pooched out that I've got circles in. If you bring your fingers together and bend your fingers forward a little bit, you can see in between your fingers there's always a little bit of a bulge there. And that's normal anatomy. And that's just where the skin isn't anchored down that hard. If we could look at the palm right in that middle area where you have all these different structures that are intersecting, and if we could roll that around and see it in 3 dimensions, we'd see how these layers are connected. And they go in different directions. They're flat, they're perpendicular, and they hold the skin in place, and they absorb the tension when you're grabbing and holding onto things. And that's important because the mechanical stress on the hand is transferred to these layers. The green layer tends to take most of the stress when you're holding on to things. And that's the layer that's most often involved with Dupuytren disease. And that is not unexpected because mechanical forces and pulling on the tissues is thought to be one of the provoking factors for Dupuytren. The biology of Dupuytren is in some ways pretty complicated, and it's not really understood. There are a lot of different things going on, but the main lead that we have on the biology is that it's similar in a lot of ways to the normal maintenance system that's in our body all the time. Our bodies have a repair system that's running all the time, and we damage ourselves, we injure ourselves all the time. I don't mean that you're always cutting yourself or bruising yourself, but anything that you do that you're sore afterward, that soreness is a sign that you've triggered the repair system. You have had an injury of some sort. So when you have an area that's been in your body that's been injured to any degree, 2 systems kick in. The defense and the cleanup team is the immune system and the inflammation system. And they go into the area and they create access for other cells, repair cells, to come in by dilating up the blood vessels, and that's why when you have inflammation the skin looks red. And they protect the area by releasing chemicals into the system so it makes it tender so you don't mess with it. And they remove debris. They take little bits of molecular debris out of the tissue, and eventually they'll release chemicals into the wound that'll make it itch so that you help take the debris off the surface. Now at the same time the repair team comes in. The repair team are specialized cells that actually come into the tissues and they transform into these super repair cells. And these cells manufacture threads to replace the torn threads of tissue that are on the inside, or cut threads of tissue. And then they set the tension by cinching up the fabric that they've woven so that the tension is just right. And when all of that is done, the alarms that the tissue is making go away and the system shuts down. And the area that's left is repaired and you're back up and running. It's not exactly the same because the threads that the repair team makes is a slightly different chemical than the threads that are normally in your body. And the cleanup team sometimes will take out not just debris and fight off invaders, but will sometimes take out the little elastic fibers in the area and change the consistency of the tissue. So this is an explanation of why when people get a lot of sun exposure, they keep triggering the sun as radiation. It injures the cells in the skin, and you get inflammation, and the cleanup team comes in and it removes little elastic fibers from the skin. So the skin is not as springy as it was. That's why sun damage causes people to have wrinkled skin, because it just doesn't rebound as well. It's not always bad. If you're conditioning for sports and you work out and you stress yourself to build up your strength and strengthen your ligaments, you're actually doing that, because by really working hard, you make little tears in your ligaments, and your body's repair system comes in and lays down extra threads and reinforces the fabric of your tissue with extra threads and makes it stronger. And so this is something that goes on all the time, and it's involved in a lot of other diseases as well. With Dupuytren, this is part of the picture. Something turns these systems on, and that something might just be normal wear and tear of using your hands, because we beat up our hands every day. But the off switch somehow is off, and so the system tends to just keep going for a long time. And the defense and cleanup team makes the area red, tender, and itchy, which is what nodules often are early on. And the repair team keeps recruiting cells into the area to do these repairs, and they just accumulate. What a nodule is actually just a collection of cells. It's not a structural change in your hand. It's just a local collection of cells, and they can go away. That's how nodules can actually go away. Cords and contractures don't on their own. The repair cells keep laying down threads of repair fabric, and they build up and they turn into a cord in the palm. And the cells keep trying to set the tension to make it just right, and they do this around the clock, even when you're asleep, even when your hands are relaxed. And so when you're relaxed and the tension keeps getting set, the cells try to make the tension so that it's normal while your hands are relaxed. And that shrinks the tissue so that over time it makes it so you can't straighten your finger out all the way. That's kind of a nutshell of the concepts of what's going on with Dupuytren. Who gets Dupuytren? I went online and looked up pictures of celebrities who had Dupuytren, and I found pictures that I could see their face and their hand in the same picture. And you might know some of these folks. We'll start in the upper left. For people my age, the guy in the upper left is playwright Samuel Beckett, who wrote Waiting for Godot. Frank Sinatra, Joe Bonsall, he's a singer and banjo picker for the Oak Ridge Boys, and you can see how he's holding that jar with his index and middle finger, and the reason is when that picture was taken, his ring and small finger were down like that. He's since had surgery and he's doing well. The woman with the close cropped hair is actress Karen Gillan. I don't know that she has Dupuytren, but I do know that that's far and away the most likely explanation for what her hands look like in the pictures. Bill Murray, comedian Chelsea Handler. President Reagan had surgery for his Dupuytren when he was in office. Above him, British actor Bill Nighy, and you can see he's holding his fingers like that. His fingers are not that bent. His fingers actually are down like this. But he has learned, as with a lot of people who have bad bends in their fingers, is that it's just easier to hold the fingers in. This is often an unconscious thing. Your body just decides, well, I'm just going to hold these in and they'll stop catching on things. And that's what you call a functional amputation. His body has given up on those two fingers. Mitt Romney on the campaign trail, a little bit in his ring finger. Pastoral painter Andrew Wyeth. And on the extreme left, Sam Elliott, handlebar mustache, gravel-voiced actor's been in a zillion movies. These are all people I just found online, and they're celebrities. The other thing they have in common is that they're all Caucasian, and that's not a surprise because Dupuytren is most common in Caucasians. Compared to Caucasian Americans, the percentage of the population that has Dupuytren disease, which is about 9% of people in the at-risk age group, Hispanic Americans have about a third of the percentage. African Americans have about a fifth the percentage, which goes along with the finding that the average African American has about 1/5 Caucasian heritage, and Asian Americans the least common. This isn't a surprise. Dupuytren is a fibrotic disease, and fibrotic diseases are ones that cause scar tissue to form where it shouldn't form, and that's kind of what's going on with Dupuytren. There are other conditions that have ancestry-based prevalence. Some diseases are more common in non-Caucasians, scleroderma, keloid scars. Some are more common in Caucasians, Dupuytren, Lederhose, Peyronie, frozen shoulder, pulmonary fibrosis, and some don't have any racial background. Family history is the single most important risk factor for getting Dupuytren disease. If someone has a parent or a sibling, brother or sister, with disease, that person has a 1 in 4 chance of getting it themselves during their lifetime. Now, not everyone who has a genetic risk will get the disease, so people can be carriers. And it used to be thought that there was a Dupuytren gene and that it was either switched on or off, and some people would have the gene but they wouldn't get the disease. But current thinking is that it's several genes, possibly 3 normal genes that don't play well together. So let's say that you need 3 genes to get Dupuytren. And let's say that I have 2 of them, but I need 3 to play, so I don't get Dupuytren. But my wife has the 3rd gene, that's the only one she has, and some of our kids have all 3 genes, and they have terrible Dupuytren despite neither of the parents having it. That's one thing that can happen. The other is it varies from hand to hand, and someone might get Dupuytren in just one hand and not the other. I've seen identical twins in which one twin had it and the other didn't. They have the same genes. And the thought behind that is that it's not just a genetic risk, but also something that triggers the disease to start. And the idea of a trigger is that maybe you have an injury that damages the tissue and starts this cascade of events going. The chance of developing Dupuytren goes up steadily with time. It's a senior disease. After midlife, the percentage of people with Dupuytren goes up pretty steadily. Men get a head start. 1 in 4 Caucasian men who are 70 years old will have some evidence of Dupuytren in their palm. 1 in 4. It's a huge number. 1 in 10 Caucasian women in their 70s will have evidence of Dupuytren in their palm as well. If you look at people who are young, it's all guys. But after age 85, it's more common in women. Age 85, there are twice as many women as men, so that figures into it as well. When you crunch the numbers, it's amazingly common. 10 to 15 million Americans in the at-risk age group, 35 and older, will have some evidence of Dupuytren. Not necessarily bent fingers. Most will just have nodules, but won't have normal hands. 500,000 to 750,000 Americans at risk for having a bad result no matter how they're currently treated with the tools that we currently have. Dupuytren has impact in a number of ways that's not appreciated. It impacts the function of the hand, it impacts social interaction, and overall health. People with Dupuytren complain of a number of things during the course of the day. Some of them are easily explained by having a bent finger. You can't get your hand into certain areas, and some of them aren't easily explained by bent fingers. Some people have trouble with their hands that you'd expect to be perfectly easy to do with bent fingers, and I've highlighted these. The list of problems that people have because of Dupuytren is fairly long. Sorry, none of these are life-threatening, but in aggregate, it is a big burden for people to have. These are common things that Dupuytren patients have complained about in surveys over the year. Together, these really impact people's lives. People feel as though they're crippled. People are really aware of their hands all the time. People feel disabled from Dupuytren. And this is something that's hard to get across to someone else because the reaction for many people is, well, it's a bent finger. How bad is that? Well, it is bad because there are effects of Dupuytren beyond just having bent fingers. People are self-conscious with Dupuytren as well, and this is a bigger issue than most people realize. In Western culture, we're very hand-oriented, and so when you meet somebody for the first time, there's a scripted dance that you do. You look the person in the eye, you give them a firm handshake, and then you get on with whatever you're going to do. And that interaction normally takes about 5 seconds. But for people with Dupuytren, it turns into a whole ordeal. People are worried, oh, should I warn the person I'm not going to give them a handshake? Are they going to grab my hand too hard and really hurt me? Am I going to have to explain what it is? Are they going to think that there's something wrong with me? And this sounds petty, but it's not. It's a big thing because we're social animals and we have to interact with other people. And this happens in social situations and also in work situations. There are also problems that people have just with normal activities of their hands. Not everyone, but many people with Dupuytren complain that their hands aren't working right. And to understand this, we'll take a tour into the neurobiology of hand movement, which is actually pretty interesting. Our hands are just an extension of our brain. And the way that our hands move depends on what part of the brain is running them. And there are two main control systems that control our movements. One is when you're in learning mode and you're doing something you haven't done before, and one is when you're in learned mode where you're doing something you've done many times before. So imagine you've been asked to go to a blackboard and draw 3 long parallel lines. Well, the way that you would do that is you'd be holding the chalk and you'd be watching what you're doing under direct vision, and you'd be constantly changing and monitoring where the position of your hand was. And the way your muscles would be acting is that the muscles that bend everything forward and the muscles that bend everything back would all be tight, pulling like guy wires to hold the hand in place. And as a consequence, the way that you'd be doing it would be slow, it wouldn't be very accurate, you'd fatigue easily because you're using all your muscles, and you'd be aware of it all the time. Now, after you've done that many, many times, what happens is your brain figures out patterns. And at some point, your brain will say, hold it, I know where this is going. I'll write a little subroutine, a little macro, so that I'll take care of this motion, because I know whenever you get to here, you always go to there. And at that point, your brain writes a script that goes from the front of your brain, where you start controlling these things, in the area where you make conscious decisions, to another part of your brain that controls your hands that you don't have conscious access to. So it seems to be automatic. And so the brain writes a little script to do that. And at that point, it substitutes, for part of it, it substitutes this learned action for your learning action. And the consequence of that is when you're in learned mode, you're much faster, you're much more accurate, you only use the muscles that you absolutely have to use, and so you don't fatigue as much, and you're not aware of it. As you practice something over and over again, bits of your learning mode are substituted by bits of your learned mode. And that is what the learning curve is. That's what muscle memory is. And the difference is that when you do something that's learned, you're really not aware of doing it. The only control points are the start and the stop point, like throwing a ball. You know where you start with the ball, and you know where the ball ends. Everything else in between is automatic. And this explains why when you're doing something that you've done a lot that is precision, there's advice to don't try to do it, just let it happen. And that's because you can get, if you try to think about what you're doing, you'll get kicked out of learned mode and be put back into learning mode. It takes a while to learn these learned activities, and so if your hand changes, it takes a while to relearn them. And this is the difference between somebody that has a bent finger because they broke it playing ball when they were in high school, and somebody that has a bent finger because they have Dupuytren. Because the person who broke their finger in high school, their finger changed and then it's stable. They learned how to deal with it, they readjusted their learned activities, and they're not even aware of it. And people will say, yeah, I don't even notice anymore, because they're in learned mode using it all the time. With Dupuytren, there are these progressive changes. The hand changes, it loses some of its elasticity, so the tissues aren't as springy. That makes the control of it not quite the same. And the finger bends occur gradually. So once your brain adjusts to the finger being a little bit bent, it bends a little bit more, and you're back into learning mode again. The consequence is that people feel that their hands aren't working right with Dupuytren, and it begins even before people have bends in their fingers. The Dupuytren Research Group has done surveys of people. The normal tests of dexterity don't show up these kinds of behaviors. If you are referred to a hand therapist to see what your coordination is and what your dexterity is, the way that test works is you'll be asked to take objects from one set of boxes and put them into another set of boxes, or assemble small items or big items, or disassemble things. Those are all learning mode behaviors. They don't test things that you're used to doing because you've practiced them a lot. So we did surveys of the impact of Dupuytren on people doing things that they are used to doing. By the time you're an adult, pretty much everything that you do all the time is in learned mode. You're on autopilot for most of the things that you do. Washing your face, brushing your teeth, driving, walking, you're not there for it. It's all in learned mode. And this explains to me something that I heard a lot when I started taking care of Dupuytren patients, which is when people get a bend that's about like this, it's very common for people to poke their nose or poke their eye when they're washing their face. My initial reaction was, how many times would you have to poke your nose before you'd learn not to do it? And the answer is, well, the finger is a little bit different every time you wash your face, and so you're always playing catch up. And it takes a while to learn behaviors, and it takes a while to relearn them. So we looked at people and asked them questions about the impact of Dupuytren on normal activities, and some of the results are here. Survey on handwriting, what people complained about as far as the effect of Dupuytren on their handwriting was right out of the textbook of being kicked from learned mode back into learning mode. People complained their writing was messy, it didn't look the same, it wasn't accurate, that they wrote more slowly, that they had to take breaks, they couldn't write as long as they used to. And this is something that you've been doing your whole life. And there were just problems that were difficult to describe. This all suggests that the Dupuytren is bouncing people out of the routines that they have trained on and into the learning mode behavior. But the important thing about this is the blue lines are people that have bent fingers. The orange lines are people that don't have bent fingers, don't have contractures. And you can see they're in the same ballpark, that people complain about these kinds of things even before they have bends in their fingers, which suggests that something is going on in the palm, in the whole hand, before the bends even begin. This doesn't happen to everybody. We did a survey of touch typing, and people complained about the same kinds of things. They made mistakes, they were slow, they had to take breaks. But of people that complained that Dupuytren affected their typing, most common complaint, 90%, was hitting wrong keys. And they were asked to describe which keys they wanted to hit and which keys they actually hit instead. And we plotted those out in the red arrows. Darker red arrows are the most common ones that reported. Every key on the keyboard was reported by somebody. These were just the most common ones. For those of us who don't touch type, the green keys are your pinky finger and the yellow keys are your ring finger. We know about these joints in the fingers, but there's another set of joints down here in the middle of the palm. These joints let you cup your palm, and that flexes these fingers, but it also rotates your ring and pinky finger over toward your thumb. So when somebody has tightness in the front, it doesn't just bend the finger forward, it rotates those fingers in toward the middle, which is the blue arrows direction of how those fingers went. Musician-specific complaint was loss of span, and the explanation for that is that there's a layer of tissue that runs around the border of the palm, which gets affected by Dupuytren, and when it shrinks, it pulls in the thumb toward the pointer finger, it pulls in the fingers together and reduces span. But there's also this effect of a contracture on the palm, on the front of the hand, that when it shrinks, will swing the fingers in. So some people will lose span that way before they even have a bend in their finger. But beyond this, everyone in these surveys of activities that people do on a regular basis and the impact of Dupuytren on them complained about the same kinds of things, that they had slowness, pain, fatigue, making mistakes. These kinds of things were reported before people had bent fingers, and they were reported after people had treatment. That is, the treatment didn't make a big dent in the percentage of people that complained about these things, which means that treating bent fingers addresses the bent fingers, but the bent fingers are only part of the problem. The Dupuytren is not just a bent finger issue. These kinds of things are missed by surgeons. This isn't in the literature. This isn't in the textbooks about what Dupuytren does. And surgeons treat mechanical problems with mechanical treatments. And when someone comes in to talk with a surgeon about their Dupuytren and they start talking about these other issues, the surgeon may hear, but they'll discount. They'll say, well, in their head they'll think, well, this person has Dupuytren and they're complaining about something else which can't be Dupuytren because it's not a bent finger problem. And it explains why patients who come in with a little bit of Dupuytren and the surgeon thinks that they're telling them good news by saying, good news, there's nothing to do, or don't come back until your palm can't be placed flat on a tabletop. The surgeon thinks they're giving them good news. The patient thinks they're being blown off. because they have these complaints and the surgeon doesn't have any answer for it. The surgeon thinks that the patient's a whiner. And the disconnect is that people aren't aware of these issues that accompany Dupuytren disease, because it's more than just a bent finger problem. Beyond this, Dupuytren can have some significant health impacts. Failed Dupuytren surgery is the most common reason for people to have an elective, non-emergency finger amputation. That's where you schedule time with your surgeon to have a finger removed in the operating room, because that would be better than the finger that you have. Fortunately, that's not a common operation, but the fact that that statistic exists is an index of how far we still have to go to get not even good treatment, adequate treatment for people with Dupuytren disease. That statistic shouldn't exist. People that have Dupuytren, aggressive Dupuytren, tend to have more health issues, problems with hypertension, cholesterol problems, depression, thyroid problems, diabetes, psoriasis, reasons that we don't know, that they're associated with Dupuytren disease statistically. People that have aggressive Dupuytren disease have a higher risk of a number of different kinds of cancers for reasons that aren't known. And the impact of that is that people with aggressive disease, Dupuytren disease, tend to not live as long as people who don't have Dupuytren. And that's another reason that we need to really work on understanding the biology of Dupuytren, because that impact, which is also not widely published, is something that needs to be fixed. It needs to be understood, and we need to have better treatments for it. Right now, the treatment of Dupuytren is a pretty simple model. You wait until there's a bend in the finger, and then you treat the bend in the finger. The window of time to get the best result of treatment is when the bend in a given joint is between 20 and 40 degrees. So on the clock, that's between 10:30 and 11:30, or 12:30 and 1:30. And the reason for that is that you don't want to do anything before the bend is about 20 degrees, otherwise it doesn't justify the risk of treatment. And after 40 degrees, you tend to get secondary changes in the joints and tendons, which then don't respond to the treatment of Dupuytren. So that's your sweet spot to get the best result. We don't really have a preventive treatment that we have good data on, and that's because we don't know the natural history of untreated Dupuytren, so we can't really assess how well a preventive treatment works. It's a big hitch. And we don't have a cure of the root cause because we don't know the root cause, but with research we will. Recurrence after treatment is really the elephant in the room. It's something that patients don't really think about, because we're all human and we all think the doctor says, well, you know, we'll do this, but there's a good chance it'll come back. And of course, you know, everyone thinks, well, maybe for other people, but not for me, because I'm going to do better. But it is an issue, particularly with people with aggressive Dupuytren, and it's really hard to predict whether someone will have a recurrence or not, what their risk is. There's soft findings that are used to kind of predict that, and they are called diathesis factors. Dupuytren diathesis refers to people that have these historical factors, such as a close family member with Dupuytren, age of onset, younger than 50, and bumps in areas other than the palm. And then there are others, but they're not as strong. But these aren't very exact. They're just kind of a general risk. But they influence the treatment recommendations that surgeons have. We have two groups of procedures that are used to straighten out bent fingers. One is open procedures, which is surgery. Regular open surgery for Dupuytren is the most common treatment for Dupuytren currently. The most common operation is fasciectomy, and the way that's done is the surgeon makes a cut in the palm and finds the tissue that looks abnormal, takes it out, and that allows the finger to straighten out. There's a supercharged version of that in which the surgeon does that, but also takes out some of the skin that's affected and replaces it with a skin graft. That's called a dermofasciectomy. There are minimally invasive procedures where you don't take anything out. You either use the tip of a hypodermic needle to cut the strings under the skin by feel, or you inject an enzyme that weakens the cord under the skin so that when you pull on the finger, the cord tears and the finger straightens out. And the relative advantages and disadvantages are that the open surgery lasts longer. Since recurrence is a problem, that's a common recommendation because it lasts longer before it comes back. And so for people that have many risk factors for having early recurrence have diathesis, it's a common thing to recommend a fasciectomy or the dermofasciectomy with a skin graft, because that lasts longer than a regular fasciectomy. That's the operation which was invented in the early 1960s. Minimally invasive procedures have a much quicker recovery, weeks instead of months, and they have a much lower complication rate, but they don't last as long. So this comes up to a funny math problem, because if you think about your lifetime and what will ultimately happen with Dupuytren, which is a chronic condition, is that the lifetime risk of having complications is the number of operations you have, number of procedures, times the risk of having complications with each procedure. Now, the riskier procedures last longer, and every time you have a repeat procedure, the risk of having a complication goes up a little bit, and the chance of getting a straight finger goes down a little bit. You get diminishing returns. And so, in some ways, it's a little bit of a wash, and the decision is often made based on what the surgeon thinks the person's biology is, because if somebody has more aggressive Dupuytren biology, they're more likely to have a recurrence. But this is just a guess. And the problem with guessing is that if someone has bad biology and has a minimally invasive treatment, they may just be wasting their time. Or if someone has pretty mild biology but has a bad bend in their finger, and the surgeon says, well, you obviously need a big operation, they might have a big operation, complications from that, and an operation that they didn't need, that didn't give them any added benefit but just gave them the extra risk. And patients live with this all the time. This is not an acceptable situation. The guesswork determines how people do in such a big way. But that is standard for Dupuytren currently because we don't have any other options. We need to understand the biology better. And Dupuytren biology is kind of all over the place. There are immune factors, inflammation, wound healing. It has to do with genes. It has to do with age. To the extent that your palm is sort of an organ, it is involved with that. It's not the common things. It's not a nutritional problem. It's not the top three hand problems, tendinitis, arthritis, carpal tunnel. It's sort of a combination of all of these. And diseases that are a perfect storm of many things going on at the same time are called systems diseases. And they are studied through a new type of biology called systems biology. What systems biology does is it looks at all the different things that are going on that are too complicated for any one person to really figure out by looking at it, and put them into a computer to make a mathematical model of it. But what we've been doing up until this point is this type of approach. This is a cartoon of what you might see under the microscope looking at Dupuytren. You'd see these cells, proteins. The matrix is the fabric that's in between the cells. And what has happened has been this kind of thinking. The doctors have looked at the tissue and said, well, you know, every time we look at the Dupuytren tissue, we find these white cells in there. So they must be the reason why there's a problem. They must be the source of the problem. So we're going to learn everything about those white cells. We're going to find out what makes them tick, and when we do, we'll know why Dupuytren happens. But the problem is that kind of thinking won't get you any closer to figuring out why this happened than if you to look at every one of these white cars, right down to their last nut and bolt and gasket. You wouldn't understand why this traffic jam occurred at this location at this time, because this traffic jam didn't start here. It ended here. The start is all out of the screen. And that's the same situation with Dupuytren. The start of Dupuytren is something else. It's not just what's going on in the palm. This is where everything converges. And that type of thing has to be studied with systems biology. Here's a map that we currently have of some of the factors that are involved with Dupuytren biology. Each one of those little spots is a molecule, an enzyme, a protein, a gene product, and the arrows are relationships between these different items. This is the kind of thing that can be modeled in a computer using artificial intelligence, using what's called computational biology. And with this, the relationships between these can be looked at and figured out in a way that the computer can understand it, and then you can model with the computer. You can make changes in several different things at a time and see how that affects the whole system. And just to give you a perspective on how complicated it is, this is a Dupuytren cell, a cartoon of it, but that whole picture of the Dupuytren cell is smaller than the diameter of one of your hairs, even if you have fine hair. And the stuff that's going on here, the bottom level, is what's going on inside the nucleus of the cell, where the genes are. And the next layer up is what's going on inside the body of the cell, where everything else is. The next layer up is what's going on at the surface of the cell, and the top layer is what's going on just outside the cell. All of that activity in such a tiny space. So it's a difficult thing to study, but fortunately we have the tools to do this. This map on the right was generated by a computer, putting in data from many different studies about Dupuytren tissue. And this is how we're going to learn to understand it. This is the basis of our research for a cure. What Dupuytren needs is to change this picture. This is where we are right now. There's a progression, and what we need to do is to make all the hands on the right go away. We need preventive treatment. We need to prevent progression of bent fingers. We need to prevent bent fingers from coming back after treatment, and we need to be able to prevent the health impact that comes from having Dupuytren overall. In order to test preventive treatments, you need to have something to test, and typically this is the model. You measure something about the disease, you give some kind of treatment, and then you let that treatment work, and then you measure that something about the disease again and see if your treatment has affected it. What you measure are called biomarkers. Biomarkers are indexes of health and disease. There are many different kinds of biomarkers. There are three kinds that relate to Dupuytren: trait, state, and rate. So your trait biomarker is like a car at the dealership. It's your make and model. It's what you start with. It doesn't change over the life of the car. It's what you can expect. You know what the car is. You know how many miles you'd expect to get to a gallon, how long it should go before it needs to be replaced. And the biologic version of that is DNA. Your DNA is with you your whole life. It doesn't change. The state biomarker is like the odometer of a car. It tells you how far you've gone, what the disease has done. It doesn't tell you what's going on right now, but it tells you the history of everything that's happened up to that point. So the state biomarker in Dupuytren that we currently have is a finger angle that we can measure with a protractor, and that tends to get worse over time. The rate biomarker is like a speedometer of your car. It tells you how fast you're going right now. And this is the biomarker that we need, because what we need for Dupuytren is we need a set of brakes to slow it down and to stop it. But you can't test brakes unless you know how fast you're going in the first place. So rate biomarkers are typically blood tests, and your blood tests can change on a day-by-day basis. Using this process to measure preventive treatments, right now we're stuck. This is the model that we'd have to use. If we had a medicine that we thought would fix Dupuytren, we'd have to measure angles, give the medicine, keep giving it for years, and then have everybody come back and measure whether or not their fingers were more or less bent. And then we'd have to guess, well, is that change in the bend or lack of change, is that just normal variation in Dupuytren, or is that an effect of the drug? It would be a guess. Nobody's going to do that research because that's just dumb. It wouldn't give you valuable information. What we need is to develop a Dupuytren blood test that shows you how bad your Dupuytren is right now, a reflection of the active Dupuytren biology. Then we could do kind of like what's done with cholesterol. If you have high cholesterol, your medical doctors treat it. The cholesterol is a proxy for your risk of heart attack and stroke. And so if you can change your cholesterol now, you can change your risk of heart attack and stroke down the road. That's the basis of testing preventive treatments. If we had a blood test of Dupuytren, we could get a measure of the Dupuytren activity, use a medicine to treat, have the person come back in weeks to months, measure the blood test again, and see whether the treatment had made a difference. And if it did, that would affect the risk of progression down the road. And you could tell if you were actually affecting the Dupuytren biology rather than having to wait years to see if someone's finger bent, which is what we're doing right now. This is the basis of our core research, the International Dupuytren Data Bank. It's a pretty simple concept. People can self-diagnose Dupuytren, usually, and so we're doing online surveys with HIPAA-compliant, secure medical forms to get information about people's Dupuytren and about their medical conditions. And based on that information, we can stratify people into whether they have severe Dupuytren, mild Dupuytren, or no Dupuytren. And then remember that list of all those chemicals that were in the systems biology map? Those are the potential biomarkers that we're going to be testing. We'll get blood samples from people and see what's different in the blood of people that have bad Dupuytren versus people that don't. And that will give us a way to, as an index, to have a blood test that we can then use to test treatments. That's the necessary step before we can start really doing meaningful evaluation of Dupuytren treatments. We'd like to change our current treatment model, which has been around since 1834, which is you wait for fingers to bend, you treat the bent fingers, you wait for them to bend again, and you just accept the fact that some people have severe Dupuytren and they're going to have a lot of operations and they're going to have a lot of complications. That's a terrible treatment model. That's where we are right now. What we need is to treat Dupuytren the way that other chronic diseases are treated, which is you get a screening biomarker, you use your biomarker blood tests to assess how well the treatment's working and adjust the treatment, and then if a person has a bent finger, you send them to the surgeon to get the simplest, safest, smallest operation to get the finger better. You don't try to cure the biology with surgery, which is what we're currently doing. People do open surgery not because it works better, but because it lasts longer. If we had something that would slow down Dupuytren or stop it, we wouldn't need any of that open surgery. Not much. And the goal is to have fewer procedures and safer procedures. Beyond that, what works on Dupuytren biology should work for Dupuytren spectrum diseases. It should work for associated health conditions with Dupuytren. And Dupuytren is a fibrotic disease, and there are other diseases with parallel biology, including pulmonary fibrosis. People get fibrosis or cirrhosis of their liver. Arteriosclerosis is a fibrosis of the blood vessels. That's cardiovascular disease. So if we had something that worked on Dupuytren, the trickle-down would be that it might give us great insights into other conditions. And that's quite a lure. This has to happen. And the steps to make it happen is we need to raise awareness of Dupuytren so that we can make the research happen, because we have to fund the research, to have breakthroughs in understanding, to develop better treatments. You are here because you're interested in Dupuytren. You are the ground troops to get the word out. Dupuytren is important to you. You need to let people know that it's a really important thing. It's a big problem. The current treatments that we have don't work for a lot of people. If we develop treatments for Dupuytren that are helpful, it may help other conditions. Talk about it when you're at home, when you're at work, with your friends. Keep it on your mind. And say the word Dupuytren. Dupuytren, 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 Dupuytren. I've had many people tell me, oh, we need to change it. Dupuytren is just too weird a word. You should call it bent finger disease or Ronald Reagan disease or something like that. But that's not the problem. The problem is people aren't talking about it in the first place. You know a lot of diseases that have weird names, and you know the name of the disease, but you don't know anybody who has it, and you know that because of advocacy efforts. You know about Alzheimer's disease, you know about Parkinson's disease, you know about epilepsy. Those are weird words, but you know about it because there have been advocacy efforts that have gotten the word out. We need to do the same with Dupuytren. We need to make it a household word. And if you have Dupuytren, that's your in. People listen to personal stories with a lot more interest than just abstract thoughts. If you have Dupuytren, say it. I have Dupuytren. I have Dupuytren. I got my first nodule about 3 years ago. I've got a couple more came in about the last 6 months. Kind of funny, huh? I diagnosed my brother's letter hose last year. It's in our family. And I didn't think about it much when we got married. I've got 4 boys. My son's mother's father had terrible Dupuytren. So we've got it in both sides of the family. And even if I never get bad Dupuytren, my kids or their kids could have terrible Dupuytren. It's a real problem. If you have Dupuytren in your family, it's your problem. You need to join the group to make this change. We need to all work together to get awareness of this. Reach out to people. Reach out to people that you think might be in a position to help advance our research. If you're a social media person, get on social media. Put the word out. If you're a Facebook person, the most active Facebook Dupuytren Advocacy group is the Dupuytren's Disease Support Group, DDSG. And join that group if you're not on it. Reach out to your contacts. If you think someone might be interested in doing nonprofit work, in possibly funding nonprofit research, reach out to them. They're out there. Asking for something greatly increases your chances of getting it. Talk to your government officials. If you have any contacts with your government officials, they need to know. I don't expect them to make a big law about something, but if they've never heard about it before, you can be the person to get that word in their ear. And the next time they hear it, they'll actually hear it and they'll know what that word means. Dupuytren Research Group is the leading effort to do this. There is no other group on the planet that's doing a big picture approach with a specific goal of finding a cure for Dupuytren disease by using tools that have been proven to work for other diseases. Most of the research that's out there is done by very smart people with very interesting ideas, but they tend to be looking through a microscope at small aspects of the disease, how certain molecules work together, or how certain aspects of surgery might be changed a little bit. We don't need an incremental change. We need a fundamentally different change. And if you haven't been on the Dupuytren Research Group website, go there, dupuytrens.org. If that's too clumsy to spell, then text DUP to 51555 and bring it up on your phone. Because our goal is to make a real difference with Dupuytren, to minimize the problems that people have from Dupuytren and from its treatment. And that's it. Thanks.